Yeah, this session was about the clinical trials that we were on, mostly from European groups, and there's quite a lot of activity going on. The results are somewhat held up by the fact that trials got interrupted during COVID. We weren't given a lot of practice-changing information, except we know that the trials are recruiting a lot of people. We know that there's interest now in what I would call non-chemotherapy agents. I worked with Gemtuzumab ozogamicin in the past, and that I was happy to see was in a lot of protocols now, and nobody is evaluating that. It's kind of accepted that's a good thing to incorporate. There are still questions about the dose, and most people go for the lower dose with less frequent use. So that seems to be built into most of the protocols that are happening. The great interest, I think, is what you can add to chemotherapy by way of small molecules. The venetoclax in particular, problem is that adding it to chemotherapy can add myelosuppression. But nevertheless, it's an interesting drug. It found its feet in non-intensive treatment in the elderly when added to azacitidine. And so that really brought to life an interest in catering for the older patients, which 10 years ago were not invited into clinical trials because they were mostly chemotherapy orientated. So they've got a genuine option now, and they've become an interesting group of patients. And I know from a regulatory point of view, the issue with them is how do you know these patients are not fit for intensive chemo? So that's been interesting, and a lot of studies have accepted the azacitidine plus venetoclax, and the issue is, do you go with 2 agents or do you go with 3 agents?